First of all, let me tell you that I really wanted to be a part of this Congress, but there were some problems. I'd like to thank all professors, especially Professor Çiçek, for allowing me being a part of this Congress, and to everyone who is contributing to this Congress. That's how I want to begin our presentation. I will be speaking about pregnancy and postpartum period clozapine treatment. As you see, clozapine is effective on many receptors, but one of the most widespread reasons for using them is treatment-resistant schizophrenia. Dopamine and BH2 and D2 antagonisms are held responsible from this. Also, hyperproteinemia risk is low, suicidal risk is decreasing. That's why we are going for clozapine. Of course, there are serious adverse effects. One is adenostasis, depression. You know, we have to be counting white blood cells regularly. Myocarditis, epileptic times, and hypersalivation are some other adverse effects. Of course, pregnancy publications are related. We have less information. Of course, I will be going into details in the upcoming slides, but we know that schizophrenia is a risk factor for mom and baby. Even if there is no treatment at all, there is low birth weight, congenital malformations, increased death of babies, and early labor. Of course, there are some risks related to this, so preterm births, congenital malformations, anomalies. So at the end of the day, even if schizophrenia is treated or not, even if we use clozapine or another antipsychotic, so we have to do a good cost and benefit analysis in order to evaluate the patient. Clozapine using mothers, which risks do they face? We know that it causes insulin resistance and it causes gaining weight. So when we compare clozapine receiving pregnancy with other pregnant, we see that clozapine, the pregnancy on clozapine has 2 times more gestational diabetes development risk. They are under risk. What are the other risks? The hypertension, extreme weight. These are some clozapine-related risks. And what kind of risks to fetus? First of all, clozapine is affecting placental barrier. It can pass through placental barrier and go to amniosis liquid. Of course, it is thought to be responsible for certain problems. For example, heart rate decrease or heart rate modulation or changes. What is this modulation? For example, when at rest, heart is under control of parasympathetic nerve system, but when under stress, it is going under the control of sympathetic nerve system. But if this change is decreasing, there might be sudden death risk based on cardiac diseases. That's why clozapine might be seen as related to increasing sudden cardiac death. As I said, in a case report, it was shown that it passed through the amniotic liquid, and we already know that it's passing through the fetal plasm. There are congenital malformations related to clozapine usage, but actually, in clozapine, on there are many malformations reported for the pregnants on clozapine, but they doesn't follow a pattern. When we compare it with the malformation ratios in general population, actually, we see that clozapine-related congenital malformations are not higher, or there is not a special malformation type related to clozapine use. But what kind of reports do we have for the pregnancy on clozapine? For example, in 2012, ozapine and clozapine had been associated with macrocephalia, risk of macrocephalia, sorry. So, incongruence between pelvic width and shoulder width, it's called shoulder dystocia. Shoulder dystocia was been also found related to clozapine and the other drug. What are the other congenital anomalies which are related to this? Gastroschisis, the horseshoe kidney, lack of testicles, hyperpigmentation, hernia, chronias, hernias, cystophabias, and other malformations had been reported in pregnancy on clozapine. But still, the risk is not higher than the general formation. In fetal serum, accumulation is claimed to increase the hypotonic baby syndrome. It was associated with hypotonic baby syndrome, which is related to lack of muscle tonus in baby, which will cause backward or the motor development impairments and other anomalies. There are more than one cases reported related to hypotonic baby syndrome. The complications at birth, speaking at complications at birth, hypotonic baby syndrome, decreased heart rates or varied heart rate, epileptic attacks, and these are called fetal serum clozapine. These are associated with clozapine accumulation or buildup in fetal serum. One of the reasons is that fetal serum has high albumin concentration, and secondly, because of ionic accumulation, there is a pH difference which causes clozapine buildup in serum.
In long-term pregnancy, concerning the follow-up of such mothers, there is very limited data. I could find only one article. In 1998, there was a mother whose child was traced, and the psychomotor development turned out to be normal for this child until 6 years of age. So there was this assessment in 2020 in the Netherlands. Women between ages 12 and 45. and using antipsychotics during pregnancy and lactation. They were assessed. Here, children below 2 years of age, similarly, were analyzed from the records, and there was no antipsychotic-related adverse pregnancy notification is noticed. So there is no significant high-level adverse pregnancy complication detected in these women concerning their children. So during lactation, there is very limited data again. However, unfortunately, clozapine's entry into mother's milk is very high, and the reason for this is it's a lipophilic drug, and in mother's milk there's high levels of lipids. This is the reason why there's this trespassing. So there is a case from 1995. 4 women lactating using clozapine. Their children were observed in this study. In one of them, there was aglonulus close developed in one of them. But then there is this contradiction here. If the mother kept using clozapine during pregnancy, maybe during the pregnancy, maybe due to the accumulation in the placenta, there might have been this complication. So it was not related to lactation, perhaps. So there's this limited data. Again, another study from 2006. 1 year lactation, mothers using clozapine, and the baby had speaking disorders. Another study from 2015 says pregnant women's children using clozapine or women lactating or during pregnancy they're using clozapine. So their children were compared with mothers using other antipsychotics. So in this study, between 2 and 6 months, the developmental tests are lower compared to the others, but in 12 months, they are not different from other antipsychotic using mothers' children, and their UPSCAR scores were similar to the children of the mothers using other antipsychotics. But there is sleep disorders being observed frequently. So aside from these, there are some warnings. So in 1994, it says, if we have to use this drug, then careful with pregnancy. So during lactation, what is recommended is that we should use it as few as possible because it might have bone marrow effects. And if we have to use it, there needs to be white glove follow-up with the infants in the first months. So there are certain various recommendations. And the biggest problem, if you ask me here, is the limited data here. So for there to be a notification concerning the drug, it needs to be used on a widespread scale. But especially when we're concerned with those who are pregnant or lactating using clozapine, there's very limited number of studies. There might be 2 reasons for the limitation. One of which is, as you know, in our algorithms, clozapine is the last stage in drug-resistant schizophrenia. So you have few use of clozapine in comparison with other psychotics. And there are some certain adverse effects Therefore, psychiatrists are hesitating from administering this drug in women with pregnancy. That's why the number of studies are rather limited. So when we come to the limitations of the existing studies, we can say that there's no control group in the first place because it is a woman who's pregnant who really needs clozapine. So we cannot come up with a control group. It would be unethical. Therefore, we do not have control groups in the studies and we cannot have them. But there are certain controllable factors that were not under control in these studies. For instance, lifestyle changes or like their low levels of vitamins, malnutrition, cigarette use, alcohol use, physical health problems, psychiatric comorbidities, and similar factors, and even polypharmacy. These are missing, unfortunately, in these studies. So they were not taken into consideration in these studies or considered to a very limited extent. But in certain studies, you see that these variables were tried to be equated at least. So as a conclusion, what I would like to say is the patients, mothers, lactating mothers, need to be evaluated on case basis. If this mother has psychotic expressions when she's not using drugs, having the risk of harming their own children, or maybe the use of another antipsychotic is more risky if it's going to lead to psychotic tantrums, etc., then clozapine needs to be used. So this is the conclusion that I derive from this. So we need to have a good benefit loss analysis on a case basis, informing the patient as well as the patient relatives about the risks to come up with a healthy solution. So then we can use clozapine. This was my conclusion. Thank you very much for your patience.